I'd like to welcome you all to the research conference here at the DCRI. We have the pleasure of having Randi Foraker from Chapel Hill come to give us a talk about neighborhood socioeconomic status and heart failure progression. Welcome, Randi.
Thank you. And thank you all for inviting me here today. I'm going to summarize my dissertation research to date today for you, and I'll leave some time at the end of the presentation for questions that you may have. So you can expect about 15 minutes at the end of the presentation to ask me questions, and I invite any questions that you do have to help me make this work better. So, as I said, today I will summarize preliminary findings from my dissertation work in progress, which investigates the association between neighborhood socioeconomic status and the progression of heart failure. And in the context of this work, the progression of heart failure is defined in three domains: rehospitalization, following an index hospitalized event; mortality, following an index hospitalized event; and self-rated health over the course of the participant's lifespan. And at this time, I would like to acknowledge my co-authors, 5 of whom are dissertation committee members, for their continued assistance as the dissertation proposal was put together and analyses were conducted and now presented. To give you some background on heart failure is a condition in which the heart has reduced ability to supply sufficient blood flow to meet the body's needs. Ischemic heart disease is the most common etiology of heart failure in industrialized societies, and other causes include hypertension, valvular disease, arrhythmias, and excess alcohol use. Population aging and improved treatment and survival among cardiovascular disease patients may contribute to the growing burden of heart failure. Over 5 million people in the United States currently have heart failure, and the lifetime risk for developing heart failure is an estimated 20% in the United States. While heart failure patients can be successfully managed out of hospital on an outpatient basis, the majority of heart failure patients are hospitalized during the course of their disease. The chart below identifies the physiologic progression of heart failure, beginning with the clinical risk factors that are both modifiable and in some cases non-modifiable, progressing through unsymptomatic heart failure and structural changes of the heart, resulting in symptomatic heart failure, or the type of heart failure that would get a clinician's attention. The phase of preclinical disease, as I mentioned, consists of both modifiable and non-modifiable risk factors. And this period in here, characterized by Dr. Charlson as the cardiac remodeling phase, stages B and C, we see that such remodeling can be caused by something like a myocardial infarction, where the person survives their myocardial infarction, but the heart muscle itself is damaged, resulting in fibrosis and decreased contractility of the heart, which can then progress into heart failure. Once a heart failure patient is hospitalized for their disease, rehospitalization among heart failure patients is common. 1/3 of heart failure patients are rehospitalized 3 to 6 months after discharge, and rehospitalizations may be due to a worsening of existing heart failure or other clinical comorbidities, more severe disease, or all of the above. Meanwhile, heart failure mortality rates increase sharply with age. In-hospital mortality ranges from 3 to 18%, while 30-day mortality is approximately 20%. 1 year might range from 30 to 50%, and 5-year, 50 to 80%. Although not a focus of today's talk, self-rated health is another outcome of my dissertation research. Self-rated health is obtained by asking individuals to objectively describe their age, often in relation to other people their age, in terms of excellent, good, fair, or poor. So self-rated health is typically measured on a Likert scale. This graph shows the natural history of heart failure measured yearly among 1,400 members of a mental health cohort. We see that self-rated health tends to be stable among men and women until about age 50, after which measures decline. Self-rated health is associated with adverse outcomes such as hospitalizations and mortality. I've talked about heart failure in the context of what's happening in the United States. However, it should be acknowledged that the global burden of coronary heart disease is also quite high. We see that more than 60% of the global burden of coronary heart disease exists in developing countries. Disability-adjusted life years can be thought of as healthy years of life lost. And this CVD, or rather CHD, atlas from the World Health Organization shows the number of healthy years of life lost per 1,000 population. And the lighter colors, the peach color, is the lowest healthy years of life lost, whereas the darker colors, the dark purple colors, are the most years of healthy years life lost. So you can see how the healthy years of life lost are distributed here around the world in terms of the burden of coronary heart disease. This measure of healthy years of life lost does not just take into account deaths from coronary heart disease, but at what age people typically die, and therefore how many healthy years of life lost there are. Coronary heart disease is responsible for 10% of healthy years of life lost in low and middle income countries, and 18% of healthy years of life lost in high income countries. Coronary heart disease is on the rise in developing and transitional countries, probably due to increased longevity, urbanization, and lifestyle changes. I spoke earlier about the causes of heart failure in developed countries. But meanwhile, rheumatic fever affects children in developing countries and may result in rheumatic heart disease if left untreated. When heart valves are permanently damaged, this may lead to heart failure, atrial fibrillation, and stroke. To show you the same type of map, only this time showing coronary heart disease mortality. And these are crude numbers of deaths from coronary heart disease from the year 2002. And on this map, you will see hearts notating the three highest number of mortality, or highest mortality rate, coming from the Russian Federation, China, and India. Those are marked with hearts. And again, we have the lighter colors indicating fewer coronary heart disease deaths, and the darker colors indicating more coronary heart disease deaths. And heart disease mortality rates worldwide are affected by these differences between countries in terms of major risk factors for coronary heart disease, such as blood pressure, cholesterol, smoking rates, physical activity, and diet. Coronary heart disease mortality rates are decreasing in developed nations due to increased prevention, diagnostics, and treatments. In developed countries, low socioeconomic status is associated with a higher incidence of coronary heart disease, higher prevalence of risk factors, and higher mortality rates. Neighborhood socioeconomic status represents the economic resources available in the community. The level of aggregation of neighborhood socioeconomic status varies. Some researchers, for example, use the zip code in order to assign neighborhood socioeconomic status to an individual living within the boundaries of that zip code. However, it is important to keep in mind that the zip code is used by the U.S. Postal Service for efficient delivery of mail and may not, in fact, represent the space that an individual might say represents their neighborhood. Meanwhile, measures such as the census tract and the smaller block group may also be utilized by researchers. And these boundaries are written by the United States Census in order to group at the census tract level approximately 4,000 persons together. And the block group is just a smaller subset of that census tract. So those are important things to keep in mind, that the level of aggregation may vary. But also the availability of data may dictate whether neighborhood or individual socioeconomic data are used. For example, if a surveillance study does not have any information on an individual's level of socioeconomic status, but rather has their address of residence, they can geocode their address of residence and determine their neighborhood socioeconomic status based on a number of census variables. Some researchers are interested in using neighborhood socioeconomic status as a proxy for individual socioeconomic status. However, in my past and this current research, I'm interested in looking at the independent effect of neighborhood socioeconomic status above that imparted by individual socioeconomic status. This conceptual diagram shows the exposure, in this case neighborhood socioeconomic status, and the outcome, heart failure progression, as well as covarying factors. These covarying factors are demographics, individual socioeconomic variables. We're using educational attainment and Medicaid status here, as well as clinical comorbidities and health behaviors. If an association between neighborhood socioeconomic status and heart failure progression exists, it's possible that the characteristics of the neighborhood environment, such as social support, access to care, and food selection and availability, are mechanisms by which this association operates. And these potential mechanisms are listed here on this slide. The conceptual framework then from the previous slide provided the rationale for future exploration of the neighborhood socioeconomic heart failure progression relationship. The research question that I will answer for you today is, if neighborhood socioeconomic status is associated with the risk of rehospitalization or death among participants with incident hospitalized heart failure. And a secondary aim of this work is to assess effect measure modification by demographic, clinical, and health behavior variables. This research was conducted using atherosclerosis risk in communities cohort data. And this cohort was comprised of approximately 16,000 persons at baseline, men and women, African Americans and whites, from 4 communities in the United States: Washington County, Maryland, and the suburbs of Minneapolis, Minnesota were primarily white. And so for these analyses, we're using white participants from those 2 study centers. African Americans were oversampled in Forsyth County, North Carolina, and sampled exclusively in Jackson, Mississippi. And approximately 4,000 persons from each study community were recruited to participate. And these men and women were ages 45 to 64 years at baseline and have been followed for approximately 20 years up until the present day. So 1,429 incident hospitalized heart failure events were identified in the atherosclerosis risk in communities cohort. We identified the index event using the first mention of a discharge code 428 in the hospital record. In order to meet this definition, participants with prevalent heart failure at baseline were not included, nor were people identified as having heart failure via death certificate. We excluded persons whose race was not white or black, or African Americans living in Maryland or Minnesota. And we also excluded those missing data on neighborhood socioeconomic status. And our final sample size was 1,342 participants for this analysis. The incident heart failure hospitalization and subsequent hospitalizations were ascertained via annual follow-up contact. So yearly, the ARIC cohort members are contacted by telephone and asked a variety of questions, one of which is, over the past year, were you admitted to the hospital overnight? And if they answered yes, then the ARIC study staff actively searches out that hospital record. So even if it occurred outside of those 4 study communities, they'll go look for the hospital record and get permission from the hospital to abstract the medical information from that record. The hospitalization may also be found using atherosclerosis risk in communities surveillance procedures, where the hospitals in those 4 communities are regularly surveilled for coronary heart disease discharge codes. And records with those discharge codes are routinely sampled and reviewed for the purposes of surveillance. And they may find a cohort record in that process, which will then be linked back to the cohort member. Meanwhile, all-cause mortality is ascertained via a variety of sources, from hospital records, that annual follow-up contact if they reach the next of kin, and National Death Index searches. For the current study, U.S. Census Tract median household income was ascertained from participant baseline addresses that were geocoded to the level of the census tract. So during the years 1987 to 1989 at baseline in the ARIC cohort, those participant addresses were geocoded to the level of the census tract, and we assigned the median household income from the 1990 census to best approximate those baseline years. And we divided the median household income into tertiles of low, medium, and high neighborhood income. For these analyses, generalized linear Poisson mixed regression models were used to estimate rehospitalization rate ratios and 95% confidence intervals that accounted for the clustering of participants within census tracts. We used Cox proportional hazards regression to conduct time-to-event analyses and to estimate hazard ratios and 95% confidence intervals. Effect measure modification was assessed, and the statistical threshold for interaction was 0.05. Covariates for the current study are shown in the table. You'll see the exposure here, neighborhood income, the outcome, rehospitalization and mortality. Potential confounders listed here were first explored as potential effect measure modifiers. We used age at the index hospitalized event, as well as a composite race study community variable, since it isn't possible to disentangle race from study community because of how the participants were sampled. Gender, as well as education ascertained at baseline, whether they had less than a high school education or equivalent, or greater than high school. Medicaid status was assessed during the index hospitalized event, whether they were a Medicaid recipient or not. Potential effect measure modifiers included a comorbidity score based on the Charlson Index of Comorbidity. And these factors measured at baseline, whether the participant was hypertensive, whether they were overweight or obese according to a body mass index, and whether they were current smokers and current drinkers at baseline. We found that the comorbidity score was found to be a significant effect measure modifier of both the rehospitalization rate and the time to event analyses. The subsequent slides will then introduce to you how this index was built and how it was used in the analyses, and then the results will be stratified by level of the effect measure modifier. Comorbid conditions such as those listed here have been implicated as risk factors for heart failure and are instrumental in the progression of the disease. Registry studies indicate that, for example, half of registry participants had coronary artery disease and up to 30% had renal insufficiency. The Charlson index components are shown here in this table, and it has been validated in the quantification of the burden of comorbidity. In studies of heart failure, congestive heart failure is removed from the calculation of the index score. The presence of the remaining codes during the index hospitalized event are summed to create a score. 2 or more points indicates a high burden of comorbidity, while less than 2 points indicates a low burden of comorbidity. This graph shows the prevalence of comorbidity index components assessed from the discharge diagnosis codes from the index heart failure hospitalization. Diabetes, pulmonary disease, peripheral vascular disease, and myocardial infarction were the most common comorbidities seen in this cohort of approximately 1,300 participants. This table shows participant characteristics both overall and stratified by neighborhood income, low, medium, and high. It is of interest to note that the largest proportion of participants with incident hospitalized heart failure were living in low neighborhood income areas at baseline, and the fewest were living in high neighborhood income areas at baseline. Participants with incident hospitalized heart failure who were living in low neighborhood income areas at baseline, this column here, had a higher prevalence of hypertension at baseline, overweight obesity at baseline, less than a high school education, and were more likely to be Medicaid recipients compared to the higher levels of neighborhood income. The following slides will show you the results from the analysis of rates of rehospitalization. So these are the repeat hospitalizations that occur following that index hospitalized event. The distribution of rehospitalizations among patients with incident hospitalized heart failure are as follows. The line here indicates all-cause hospitalizations, whereas the shaded bars show CVD-related and heart failure-related. of comorbidity. These graphs, shown side by side, show rehospitalization rate ratios and their 95% confidence intervals by neighborhood income. On the left-hand side of the slide, you'll see a graph for all-cause rehospitalizations, and on the right side, a graph for CVD-related hospitalizations. We see among participants with a high burden of comorbidity in this all-cause hospitalization graph that participants from low neighborhood income areas had a higher rate of rehospitalization compared to those from high neighborhood income areas within the same strata of comorbidity. However, we do not see a difference between medium neighborhood income and high neighborhood income groups within this level of comorbidity. Nor do we see a neighborhood income effect over here where the comorbidity burden is low. If you'll shift your attention over here to the CVD-related hospitalizations graph, you'll see that again, within this group with a higher level of comorbidity, we see persons living in low neighborhood income at baseline had a higher risk of rehospitalization compared to the high neighborhood income group. And again, we do not see a relationship with medium neighborhood income or a neighborhood income effect over here in the lower burden of comorbidity group. The next slide will change just this graph over here to heart failure-related hospitalizations. And with heart failure-related hospitalizations only, we do not see a neighborhood income effect regardless of comorbidity burden. Among participants with a high burden of comorbidity, those living in low neighborhood income areas had a higher risk of all-cause and CVD-related hospitalizations compared to participants from high neighborhood income areas at baseline. An increased rate of hospitalization among participants living in low neighborhood income areas with a high burden of comorbidity may be due to issues relating to access to primary or specialized heart failure care out of hospital. For example, if sicker heart failure patients from low neighborhood income areas utilize the hospital instead of an outpatient clinic as their primary source of care, this may explain the higher rates seen among that group in particular. And if we work to reduce neighborhood income disparities, this may help lower rates of rehospitalization among persons at highest risk. Now I wish to present the time to event analyses. And these analyses will be presented to you in terms of time to first rehospitalized event, time to death, or time to rehospitalization or death, whichever comes first. And I will put that into context for you as the time comes. First, to put this into perspective, I'm showing you on this graph the cumulative incidence of death, rehospitalization, and rehospitalization or death occurring among ARIC Cohort members with an incident hospitalized heart failure event. The x-axis does not begin at baseline. It begins at the index heart failure event and follows people forward 30 days up until 5 years. So these time points indicate the time elapsed since the incident event. For example, of those with an incident hospitalized heart failure event, more than 20% had been rehospitalized or had died at 30 days. Nearly half had been rehospitalized by 6 months, and about 20% had died within 1 year. This table compares participants who had been rehospitalized at least once or had died from their incident event through the end of follow-up 2004. They comprise this column here, compared to those who had not been rehospitalized and had not died up until the end of 2004. We see that a higher proportion of those who had been rehospitalized or had died were women. They had less than a high school education, and they had a higher burden of comorbidity compared to those who were not rehospitalized or had died at the end of follow-up. This graph shows median times to event for rehospitalization or death, the composite endpoint. And we see over here that among participants with a high level of comorbidity, participants from high neighborhood income areas tend to have longer survival times compared to those from low and medium neighborhood income areas. There was not a similar dose-response relationship when considering only those participants with a low comorbidity burden. These survival curves show participants with a low comorbidity burden experience better survival compared to participants with a high burden of comorbidity. I don't know how well you can see this, but these top 3 lines showing better survival over time are grouped together, and those all represent participants from, not from low comorbidity areas, but rather who had a low level of comorbidity. And then these lower 3 lines here represent participants who had high levels of comorbidity. So we see from this survival curve that participants with a low level of comorbidity tended to survive longer compared to those with a high level of comorbidity. And within that low comorbidity strata, the lines that persist out here the farthest are low, the black line, medium, the red line, and high neighborhood income, the green line. Putting that into perspective with hazard ratios and confidence intervals, again, these results are stratified by level of the effect measure modifier, with the high comorbidity burden here and the low comorbidity burden here. These results are divided into time until all-cause rehospitalization, time until death, and time until all-cause rehospitalization or death, the composite endpoint. In fully adjusted models, accounting for all potential confounders, participants living in low neighborhood income areas were at increased hazard of all-cause hospitalization and rehospitalization or death compared to those from high neighborhood income areas, regardless of comorbidity burden. But also, among those with a higher level of comorbidity, participants from low neighborhood income areas also had a higher hazard of death compared to those from high neighborhood income areas. In summary, accounting for all potential covariates, participants living in low neighborhood income areas at baseline with a high burden of comorbidity were at greater risk for both rehospitalization and death following an in-hospital heart failure diagnosis. Potential mechanisms may be similar to those discussed earlier with respect to the rehospitalization rates. Access to care or care-seeking behavior may be different for patients of lower versus higher neighborhood income. At this time, I would like to point out some of the strengths of the current analysis. The strengths of this study really represent the limitations of existing studies, namely limited follow-up and homogeneous populations. The ARIC cohort has nearly 20 years of follow-up for ascertaining hospitalized events as well as all-cause mortality among cohort members. Participants come from geographically and racially diverse areas of the United States. In addition, in our study, both neighborhood and individual measures of socioeconomic status were available, so we could get at the independent influence of neighborhood socioeconomic status while taking into account individual socioeconomic status. Indeed, when accounting for educational attainment at baseline, the findings for neighborhood socioeconomic status remained robust. Limitations of the existing study are as follows. There are a lack of information in the ARIC cohort regarding outpatient management of heart failure and emergency room visits. This outpatient management of heart failure will be captured and has been captured beginning in 2005 for cohort members. So this will be addressed in future ARIC analyses. In addition, ICD-9 discharge codes were used to identify the existence of heart failure, but we are unable to distinguish between acute or chronic heart failure. So for example, was this index hospitalization truly an incident acute event of new or recent onset heart failure, or was it a hospitalization due to an exacerbation of existing disease or existing symptoms? And had they been managed out on an outpatient basis prior to being admitted? So in other words, was this really a repeat visit for chronic heart failure? Hospital record abstraction was also used in order to capture the comorbidity burden among these patients. So we are limited by the presence or absence of the discharge codes in order to give the participants points or not for the comorbidity index. It should also be acknowledged that there were a limited number of African Americans living in certain neighborhood income categories at baseline, which may have limited our power to detect effect measure modification by race study community. So accounting for all potential covariates in the analysis of rehospitalization rates as well as time to event, participants living in low neighborhood income areas at baseline with a high burden of comorbidity were at greater risk for both rehospitalization and death, as well as a higher rate of repeat hospitalizations, both all-cause and CVD related. Shorter median times from the index event to readmission among those living in low neighborhood income areas with a high burden of comorbidity appeared to be a strong influence on the combined rehospitalization mortality endpoint, as low neighborhood SES by itself was not a predictor for heart failure survival across levels of comorbidity. In particular, rehospitalization occurs more often and more quickly among participants living in low neighborhood income areas, especially those with a higher burden of comorbidity, as identified during the index hospitalized event. In this context, neighborhood income is associated with heart failure progression. In the context of increasing hospital discharges for heart failure and a consistently high rate of mortality from the syndrome, it's critical to take into account social and economic forces which impact heart failure, rehospitalization, and death in the presence of individual demographic, socioeconomic, and clinical risk factors. Differences by neighborhood socioeconomic status in survival free from readmission or death may have important implications for the management and treatment of heart failure patients. And I've pointed out here implications for future research, which may include targeted interventions to reach those most at risk for rehospitalization and death. And these interventions may be at the neighborhood level in order to increase access to primary care or specialized heart failure care in lower income neighborhoods. They may focus on prevention programs to prevent the occurrence of heart failure among people living in lower neighborhood income areas. Also, this may be an opportunity to investigate in-hospital treatments specifically targeted, for example, at patients with a higher burden of comorbidity, more aggressive treatments perhaps, and exploring the effect on rehospitalization and death on a basis of those treatments. And also, it may be of interest to explore of those who are managed, adequately managed out of hospital, what are the triggers or the precipitating events that causes them to be admitted to the hospital in the first place? And can we target those events and perhaps prevent those events from happening? So those are potential areas of future research. I also wanted to tie this back in to a global health perspective where socioeconomic status is also a risk factor for coronary heart disease. So this goes back to the World Health Organization and the Atlas of Coronary Heart Disease and Stroke that I showed those maps from earlier. And here we see, for example, I know that it's hard for you to see if you're in the back of the room, educational level and obesity in Italy. We see income and obesity relationships here among people in Saudi Arabia, the prevalence of diabetes by income in India, smoking by years of education in South Africa, smoking and occupation in Uganda, as well as the prevalence of high blood pressure by income in Trinidad and Tobago. So you can see that socioeconomic status is in and of itself a risk factor for coronary heart disease risk factors, and also the coronary heart disease burden worldwide. Only 8% of published cardiovascular disease research is from low and middle income countries, yet developing countries shoulder 80% of the disease burden. So there exist many opportunities to expand the type of research that I presented today into populations around the world. And I thank you very much for your attention, and I welcome any questions that you may have. Thank you.
Thank you, Randi. As usual, wait for the mic if you have questions. Okay, I had one that was on your initial maps.
Yes.
I thought China was a very interesting piece because on the first map they were very low in the influence on life years, but on the second map they were very high on total mortality, and that seemed to be a disconnect.
Yes, the life years, the disability adjusted life years takes into account life expectancy.
So if you start off with a very low life expectancy, you don't lose much.
Mm-hmm.
Okay.
Mm-hmm. So that may be the basis for that discrepancy.
Thank you.
I have a couple of questions. First, in the modeling, are you able to take into account the etiology of the heart failure? In other words, one might imagine that in certain populations, particularly a black population, that hypertension is more common and that hypertensive heart disease might be more common than coronary heart disease. And there may be important implications in terms of the outcome, but that's not in the, hypertension's in the model, but the etiology of heart failure is not in the model. Is that correct?
That's correct, and that's a limitation for using the discharge code 428 to identify the incident hospitalized heart failure event. We don't have additional information on the etiology. One way that we could handle that is looking at participants with hypertension at baseline. So, in other words, isolating the effect, or excuse me, the analysis to those with and without hypertension at baseline. And we could compare those two groups, but that would just get at the hypertensive etiology of the disease.
My second question has to do with the other things that are in the database in terms of what might actually be the problem here. Is medication in the database?
Medication is collected at the visits, at the 4 in-person visits, and information on medication is collected at annual follow-up.
But did you include that in any of the modeling, whether or not they're on beta blockers, ACE inhibitors, that sort of thing?
We did not include that, and we also have information on medication from that index hospitalized event. If they left the hospital with those medications prescribed or given to them at discharge, and so we could certainly incorporate that into these analyses.
I mean, that may be worthwhile because there may be some issues in terms of access to medications, et cetera, which brings me to my last comment. It seems that you've made the assumption that as to the reason why people are being rehospitalized, that they don't have access to care. Do we know that to be true? In other words, is there, do you have information as to where there are the clinics, the hospitals, et cetera, geospatially mapped to these communities so that you can actually say that there's not adequate representation of access to providers, et cetera?
Sure. So this was a hypothesized mechanism. Because we found this association between neighborhood income and rehospitalizations, for example, the hypothesized mechanism says, well, maybe there's something that has to do with the neighborhood, which leads us to think about access to care. However, over the course of the ARIC Cohort study, beginning back in 1987, we do not have the historic plots, if you will, of where the clinics were over time. And when I go to look for that information, I can find very contemporary information on where those clinics currently are, but that's not necessarily true of where they were. And if the clinics have moved, or indeed moved into, let's say, lower income areas over time. We don't have that information available in the data. It would be something that we would have to historically construct.
Got it.
Other questions? Mike's coming.
Hi, I just have a quick question. Is it possible that you're seeing a greater amount of hospitalizations and rehospitalizations and deaths in the lower socioeconomic communities because maybe that is their first point of, the hospital is their first point of contact when they have health issues, and because that they don't, where in the higher economic status they may have a GP or they may have greater access to education and intervention before they need hospitalization, whereas the lower economic, they wait until things get really, really bad and their hospital is their last choice.
That could be, and that is definitely a limitation of the data that we had available for this analysis, because we don't know what was going on prior to that hospitalization. We don't know how many people were being adequately managed. We don't know how severe their disease was once they arrived at the hospital. We could get a handle on their comorbidity burden, which is what I showed you in the results, but that doesn't necessarily speak to their heart failure. It speaks to other illnesses that they may have once they get to the hospitalization. But you're right, beginning the analysis with a hospitalization assumes that that's the incident event, and in fact, it may not have been. And it also isn't a homogeneous definition for heart failure. This could be very, very sick people waiting until the last minute to arrive, and therefore their survival will be shorter because they're very, very sick. Or it could be someone who has been diagnosed out of hospital, is maintaining, but got hospitalized for some other reason, but a 428 discharge code was present in their record, and we detected it. So all of this, unfortunately, is unknown, but that's a very good idea. Very good explanation.
You probably said this, but just remind me, why did you treat the comorbidity index as a dichotomous variable instead of continuous?
I did not address that, but in previous research, the comorbidity index was divided at 3 points. 3 points or greater being a higher burden, and less than 3 points being a lower burden. And because all of our participants had heart failure, we took that point out and dichotomized it rather at 2 points. I did not look at it continuously, but that's definitely an option moving forward.
But in general, the Charlson index is incredibly skewed because it was developed on an in-hospital ICU setting. So it's you're not going to find very many people who
you don't get a lot more information by spreading it out.
No. We've tried that in our own analyses, and you basically collapse it to 2 and maybe 3 groups if you got a big enough sample size. Oh, Randi, thank you very much. This was really fun.
Thank you.